Hello, good evening, one and all. This is our second live pedagogy PG program conducted by Kasoga. It is the dream of our President, Dr. Rajashri Paladi. Rajashri Paladi, ma'am, over to you.
Namaste, everybody, and welcome to this event wherein we have this pedagogy which will smarten your brains to know what you can do best in the given point of time and recall all that you have learned in your postgraduate training. This 5 minutes is a crisp presentation which you can do on the spot, extempore, when you're given a topic, and it will help you to recollect all that is needed about a particular topic. And I'm very glad that you are all taking so much of interest in participation. And thanks to Dr. Manjula for taking the initiative and drive, and also the workforce behind the screen is Dr. Rashmi and Dr. Srimati, who have been such a darlings to do all the work. And welcome everybody for this wonderful learning. Without losing much time, I think we could go ahead with the program.
Did Bellet sir joined back?
Shobha Gudi ma'am has to say something. Shobha Gudi.
I have joined back, madam.
Yes. Okay, sir.
Thank
okay,
you,
sir.
Thank you.
My PGs have also joined, madam.
Thank you, sir.
Yeah,
Shobha,
I have also, Manjula. I have also shared this with my postgraduates. I have
Nice.
told them to join. Let us hope that they do. And I'm very happy that you have started this program, Rajashri. It is indeed heartening to see at least there are 35 PGs who have joined today. I hope this number will increase and it will become 100 because we have so many medical colleges in Karnataka. So probably we need to kind of, raise this
Awareness
the
and
banner
also
for
advertisement.
pedagogy in a very big way, and break down the, tell them what it actually means when we are sharing the information, so that they don't get alarmed by a feeling that they don't know what it is. So once they understand what it is and it is for their skill development, their capacity building, I think they are definitely going to show higher interest. But anyway, it is a wonderful start and it's going very strong. So congratulations to Manjula and Rashmi and Srimati. And also I appreciate Rajashri for this, for starting this program. Thank you so much. Thank you, Manjula.
Thank you, ma'am. Today we are having 5 medical colleges, KVG MC Solia, JIMS Gadag, MS Ramaya, JIMS Kalburgi, MIMS Mandya. So without wasting much time, and today's expert is none other than our well-known professor, expert, Dr. M.B. Bellet, sir. We are happy to have you, sir. Please, I need your feedback.
Yeah, good evening, Dr. Manjula, for catching hold of me and bringing for this session. Rajashri Palladi, she was behind me for this to see that. Before I proceed, Dr. Rajashri and Manjula, that first we should know what do we mean by pedagogy. Pedagogy is a way of encouraging learning.
Sir, ನಿಮ್ಮ camera ಸರಿ ಮಾಡ್ಕೊಡಿ sir.
No. Okay. Really. Sorry. Can you see now?
Okay, sir. Yes, sir. Yes, sir. Yes, sir.
It's a way to encourage learning. The information, be it a technology, be it a skill, or even the communication. So pedagogy is a means to encourage learning in all these aspects about a particular area or the subject. So PG is when they are asked to in the examination, they will be given like an extempo. It is to evaluate how much in depth they have read without even prior information, how much they can talk about a particular topic. It really assesses the intellectual skill, the knowledge, as well as the practical skills when they are faced. I was going through your previous one of the pedagogy session of the inversion girl who had spoken. She never, first of all, is her grading. You have given that grading of the inversion was not accurate. There is a change, and she was telling that the depending on the degree, the examination findings. So in a hurry, probably she must have done, but we need to be very systematic in our presentation also. Though it may be 5 minutes, they can take another half a minute required, but they should make it a systematic presentation, encouraging, because when they talk to the patient also, it's an education to them. When they talk to the colleagues also, it is important, and when they talk to the paramedical also, it is important. So just a message I gave on what is the pedagogy, why we are doing that. Thank you.
Thank you, sir. Thank you so much. So, students, hope so. Sir has made it clear, like how you should supposed to do it in the examination whenever you get this topic. So, without much wasting the time, let us begin with our first student, Sindhu from KBJMC Sulia. Sindhu, you are ready?
Yes, ma'am.
Yes, your topic is partograph.
Sindhu, put your video on. Yes, good.
All of you put your video, students, please.
Yes, Sindhu, your timing starts now.
Yes, ma'am. Good evening, one and all. Today I'm
Aima, are
going
you there? Switch on all the students, please switch on your videos.
Yes, Sindhu, carry on, please.
Start, ma.
Good evening, everyone. Today I'm going to talk about partograph. Partograph is nothing but the graphical representation of the progression of labor, where we document cervical dilatation and the descent of the fetal head, where we also document the maternal vitals and the fetal heart rate. Coming into the history, how we came into partograph came into the picture. First, the Friedman curve was developed in 1950s, who introduced the progression of labor like with sigmoid curve. Then the Philtop and Castle came, who actually introduced the terms alert line and action line in 1970s. Coming to the clinical partograph, what we are using now, like before 2020s, that was developed by WHO, that is modified partograph at around 2020, where only active phase was involved, latent phase was removed. Now in 2020, after 2020, now we are currently using labor care guide for the progression of assessment of the labor. Coming into the components of the partograph, it usually includes all the patient details, then the gestational age, then the obstetric score, and the date of admission, date of examination, and the expected date of delivery. Then coming to the cervical dilatation, we represent it by the X against plotting X. Then the descent of the head is denoted by O. So about the condition of the membrane, whether it is intact or ruptured. If it is intact, we indicate it by I. If it is ruptured, we have to comment about the amniotic fluid. C for clear, M for meconium stain, then B for blood stain. We also comment on the molding, that is plus grade, different grades of molding, plus 1 plus 2 plus and 3 plus. So then we also document FHR, fetal heart rate. Actually practically we have to document every 30 minutes, but we have to check every 15 minutes the FHR. Coming into the maternal vitals, usually maternal vitals, pulse rate is checked every 30 minutes, then BP is checked every fourth hourly, temperature and urine output, it is checked every second hourly. So we also document uterine contractions based on the severity of the contraction. like we usually shade the boxes less than 20 seconds, like light shade, then 20 to 40 seconds we increase the shade, then full box will be shaded when the contraction is lasting for more than 40 seconds. Here we say we plot the strength, frequency and duration of the into the alert line and action line. When do we start actually plotting the partograph? Usually at 4 centimeter, which is considered as active phase of labor. So 4 centimeter, 4 hours right to the alert line is the action line. So if any progression of labor, if we are plotting at 4 centimeter, if it is crossing alert line, we have to assess three things. We have studied the three P's, that is passenger, the power and the a passage. Usually the power, that is uterine contractions, if they are not adequate, we have to reassess. If the membranes are ruptured, we can do artificial rupture of membranes. If the membranes are already ruptured but still the patient is not progressing, we can augment with the oxytocin. Then coming into the crossing of the action line, it usually tells about the progression of the labor, that is prolonged labor. If it is crossing alert line, action line, we have to intervene with operative vaginal delivery like ventouse or forceps, or if indicated whether in fetal distress or metal exhaustion, we can take her into cesarean section also. Coming into the advantages of partograph, why it is important in low resource test settings where the higher parameters are not available, we can use this partograph where we can identify the delayed progression of the labor and we can refer to higher center. And for medical legal purpose, coming into the disadvantages, it is rigid. We always expect 1 centimeter per hour progression, which is not happening in every patient. So this might necessitate the unnecessary intervention because of the 1 centimeter per hour progression of the labor. So other thing is there is no studies shown that there is no marked in decrease in cesarean section rate with respect to partograph. So nowadays, because of all these, WHO has developed LCG, that is labor care guide, where we start plotting the graph from 5 centimeter, which is taken as active phase. Here we also document about the companionship, the posture of the patient during the progression of the labor, then the oral fluids administered, then the position of the patient during the progression of labor. It's individualized care compared to the partograph, where partograph we usually depend on the alert and action line. So now the partograph has been replaced by LCG.
Well, sir.
Yeah. Her name, good name, please.
Sindhu.
Sir.
Sindhu, very nice coverage of the topic. I don't know, timing is kept by Manjula. Whether
Yes, sir.
that,
It was on time.
yeah. See, first always give you positive points. You covered definition, but it is not very correct definition. But importance of partogram, first thing you should tell always why we need partogram. What was that? Secondly, the history you have covered very nicely. Then it is not Philtop, it is Philpott in 1971 first used this, though Friedman gave that. And secondly, you must know this, there is a difference between the WHO partograms which were developed in early in the first decade to 2020. Before that, there was a simplified, there were some things were taken away, and the duration was also seen. So, overall, what point I can give you out of 10 marks, I can give you 6 marks, and you need to cover why this partogram point is not covered. And in the history, you covered relatively very well, but the types of, there is an entity called as paperless partogram also. And then the purpose of this partogram, and the definition, correct definition of partogram is, it is a composite record of the labor, the process of labor, the fetal components, that's the fetal condition, maternal condition, and progress of labor, and the changes associated with in a graphical manner. Okay, and LCG you need to have, currently you need to modify on that, because they changed the active phase when to take active, and then its implications, and they have also changed the how frequently we should do the per vaginal examination, as well as the most important component, they have made second stage of labor into two components, propulsive and expulsive phase, and the duration of second stage
Express.
has been changed. But overall, I can give you 60% marks. I want you to get more marks. You need to improve your presentation, but I liked the way you confidently you spoke, and you are very, very, confident in your approach. Those are some of the points. I think probably something more if you would have read LCG, something more about the partogram if you would have seen, you would have been better. I think there is a scope for till to improve. Please do take care of that. Rajeshri, you can add on.
Yeah, thank you so much, sir. That was an expert speaking about the very, very important topic of pedagogy, because we know that most often our decision can change even in the absence of a, as a consultant or a senior doctor in the labor ward, just by looking at the partograph and having the pictorial depiction, even electronic, as sir mentioned. But B of importance is that the labor care guidelines are changing. You cannot stick on to the old concept of guidelines. And now the very important aspect is that the latent phase of labor, that is the 5 centimeters, which we take as the latent phase of labor, and the revised labor care guidelines. So recently there was a talk wherein it was said that why was this 3 centimeters, 3 hours or 4 hour considered as an interval to assess the patient? Is that much is the time you take to refer to the patient to the higher center wherein she can undergo a cesarean. So this was basically developed and devised to cater for the patient who are in the remote place wherein they don't have the access for the immediate emergency cesarean section. So at least you require this period of time, 2 to 3 hours of time by the time the patient is shifted to the higher center. So there is a logic as to why it has to be done at a specific interval of time. So these are evolving, these are changing, and we need to adapt ourselves to the modern challenges so that, partogram will become a means, it will become a documentation. And in any of the medical legal cases wherein there is a discussion in the even at the administrative level, even the DC nowadays is involved in assessing the maternal mortality rate. It is mandatory that you have the partograph attached to the case paper. So it's not a very simple aspect that you're dealing with. It's a very important aspect to know the details of the partogram, because one, it helps you to take this patient for emergency cesarean. Second, there's a documentation and everybody knows the indication why you have done the cesarean section. The first thing your boss will ask when you enter the presentation in the post-op rounds is, what was the indication for the cesarean section? So this becomes a very important document. And third, for medical legal reasons also. So
He covered that. He covered that medical
yes,
legal.
Yeah. So that is the importance and significance of knowing the partogram. Very well done. And sir mentioned that, your flow was good, your confidence was good. And this is how we expect the postgraduates to, just talk at the dot of a topic given. And that shows that you have a real knowledge of what you have read. Thank you so much.
Students, note down all the expertise points so that you can prepare well next time and for your exams too. Now, I also welcome all the HODs of today's colleges, Dr. Geeta, Dr. Hanuman, Dr. Jyoti GS, Dr. Usha, and Dr. Savita. Please, I also welcome you all, and you can also please give the input if you are having it. Next, we are moving on to the next student, MS Ramaya, Dr. Deepthi.
Yes.
Your topic is on insulin in GDM.
Okay, ma'am. Good evening, ma'am. First of all, ma'am, in GDM, first I'll be talking about what is GDM. That is gestational diabetes mellitus. It is any degree of glucose intolerance that is first seen during pregnancy. So I'll be directly talking about the management of gestational diabetes mellitus. So what is the aim? So the main metabolic goal in gestational diabetes mellitus is to maintain the fasting blood glucose less than 95 milligram per deciliter, and the 1 hour postprandial less than 140 milligram per deciliter, and the 2 hour postprandial to be less than 120 milligram per deciliter. So first we'll be starting with medical nutrition therapy. That is, we advise the patient for 2 weeks and then later check her 2 hour postprandial blood glucose levels. So for the medical nutrition therapy, the diet will be advised as the carbohydrate should be less than 45%, the proteins 25%, and the fats to be 30%. And the fats should be mostly of unsaturated fatty acids, and the saturated fatty acid should be only 10%. So with the medical nutrition therapy, we also advise exercise, that is at least 30 minutes of aerobic exercise, or minimum she can walk for at least like 10 to 15 minutes after her meals. So this exercise should be advised for at least 5 times in a week. So why exercise is important is because it, especially walking after your meals, reduces the postprandial blood glucose levels, and it also reduces the requirement of insulin in pregnancy. So after medical nutrition therapy and exercise, after she has followed it for 2 weeks, we check her 2-hour postprandial blood glucose levels. If it is less than 120 milligram per deciliter, then we continue with medical nutrition therapy. If it is more than 120 milligram per deciliter, then we will start insulin, because insulin is the drug of choice in pregnancy, because insulin is safe in pregnancy as it doesn't cross the placenta. So first I'll be, so what are the indications for insulin in pregnancy? So one is gestational diabetes mellitus, when after starting medical nutrition therapy and her postprandial, 2-hour postprandial blood glucose is more than 120 milligram per deciliter, and if she is a pre-gestational diabetes mellitus, or if her postprandial blood glucose is more than 200 milligram per deciliter. So these are the indications for starting insulin in pregnancy. So I'll be talking about the classification of insulin. So we have short-acting insulin, where the onset of action is 15 minutes. Example is Lispro and Aspart. We have, this is the ultra short-acting insulin. We have short-acting insulin, like we have the regular, example is the regular insulin, where the onset of action is 30 minutes, and the duration of action is 4 to 6 hours. We have intermediate acting insulin, that is the NPH insulin, where the onset of action is 1 hour and the duration of action is 10 to 14 hours. We have ultra long-acting insulin. Example is the Glargine and Detemir. So what the most institutions suggest insulin in pregnancy is the short-acting and the intermediate-acting insulin. Studies have shown that even the ultra short-acting insulin is safe in pregnancy, but there are no long-term studies on long-acting insulin to be safe in pregnancy. For example, the Glargine, few studies have shown that because of the mitogenic action, it has high affinity for insulin-like growth factor, and it increases the fetal growth. That is why there are no long-term studies which suggest that long-acting insulin is safe in pregnancy. So what we usually use is the short-acting and intermediate-acting insulin in pregnancy. So coming to first, usually if we are starting insulin, it's ideal to admit her and do 6-pin GRBS monitoring. So once, and also we teach her how to self-administer insulin and do SMBG charting at home when we are discharging her. That is the self-monitoring of blood glucose. So when she's once she's thought about self-administration of insulin SMBG charting, we can discharge her once her blood glucose levels is adequate. So there can be what are the disadvantages of insulin? I mean, more than disadvantages, complications. So the complications can be like pain at the injection site because of the repeated injections. There can be pain. There can be lipodystrophy, and also she should be warned against hypoglycemic symptoms once, like when she is administering insulin at home. There is something called as, I'll be explaining with the two phenomena, that is Somogyi phenomenon and Dawn phenomenon. So Somogyi phenomenon is the fasting hyperglycemia with nocturnal hypoglycemia. That is nocturnal in the sense when you check her blood glucose levels at 3 a.m. So that is the Somogyi phenomenon. it is because of that's because of the more insulin that is given at the bedtime. So what is the advice? You need to reduce the bedtime. You need to reduce the bedtime insulin. So that is Somogi phenomenon. There's something called as dawn phenomenon, whereas that is fasting hyperglycemia, but there is no nocturnal hypoglycemia. So that is because of the reduced bedtime insulin. So what is the advice? You need to increase the bedtime insulin. So these are the two phenomena important.
I think your time is up. Students, one more important point to be noted is not to keep anything in front of you to refer or to see anything. This is exactly how you are going to present in your exams. Don't keep the laptop, don't keep your another mobile, don't keep your study material in front of you for you to refer. You please be honest, so that this is a real exercise, and which is going to help you for your examination. This is for all of you. Over to you, Bellat sir.
No, topic, what was the actually title of the topic?
Insulin in GDM.
Yes.
Only GDM, right?
Yes, sir.
Dr. Dipti, you covered very nicely. Important point is you should know that GDM, there are two varieties. You should be telling that classification. That is, over diabetic becoming pregnant is also gestational. She is pregnantly with a pregnancy with diabetes. And over diabetes, of course, we should also see why we should use these drugs. What is your objective should come first. Because the hyperglycemic control, why hyperglycemia control is important? What is the effect on the baby? What is the effect of the teratogenicity in the hyperglycemic woman who becomes pregnant? What are the teratogens? Those points are not being covered. This is very, very important. And gestational diabetes does not cause congenital anomalies if it is developed actually true gestational. Non-diabetic woman becoming pregnant. So what is the level? You covered very nicely on that insulin when we should give after MNT. And you covered very nicely the sugar levels. Of course, probably you wanted to refer to these numbers, which may not be possible, but how do you start? How do you give insulin? It is also very important. And what instruction you should be giving. These points are covered nicely. Though it is a little difficult topic, I can agree with that insulins, because you should have also told that nowadays insulin, apart from this, we are combining oral hypoglycemic drugs, which are safer, which reduces the dose of insulin. So there is a combination of, metformin can be used, even sitagliptin can be used. These are all being tried in the later part of the pregnancy. Hypoglycemia is more dangerous than hyperglycemia. That also you should take into. And one important message I would like to you read, there is one COG on diabetes in pregnancy, where the teratogens, what are the teratogens in diabetic woman? You should know them. Okay. So overall, I am giving you 55, not out of the 60 also. I'm sorry for that. So 55 marks, because its importance is why we should treat should come first, and then method of treatment and level of control, how we should gain, and what confidence we should build in the woman. And she should be also explained what all complications she is prone for. And then postpartum, you didn't mention. You should stop the insulin in GDM patients immediately. Otherwise, they will go into, and little bit about intrapartum management should have been covered. Anyway, I still give you 55 marks. You are still passing. Thank you.
Thank you, sir.
Thank you, ma. Next, we are going
Rajeshri wants to add anything.
Jim's
Yes,
Gadat.
Can I?
Rajeshri or Shobha Gudi?
Yeah.
Yes, please.
Most of the points I agree with what Bennett sir said. There's one particular comment that Deepthi made, is that she was talking about the diet and exercise. Be specific in your given time of 5 minutes. That will give you more leverage to add in more consolidated points about the given topic, rather than divert from the topic. And very much so, as in how giving insulin has enhanced the outcome of pregnancy, pregnancy outcome, and also morbidity and mortality, neonatal morbidity, and sometimes, IUDs were. So what is the incidence and how we have been effectively able to manage diabetes by using the insulin?
Now, Rajeshri, one more point that she didn't cover is, see, generally in the later part of pregnancy, aerobics are not advised, number
Yes.
one. And then the hypoglycemic effects on the baby postpartum, this has to be, there are 3 hypos and 1 hyper. They should talk about that. It's very important. And Somogi and Dawn phenomenon, I really appreciate that. And that was the need for the method of giving insulin will be guided on that. Thank you.
And the incidence of diabetes is so much so now, gestational diabetes, that it is mandatory for all the PGs to learn more about, diabetes, which is because India is the diabetic capital of the world. Now we have been effectively been able to take care of hypertension to some extent, and eclampsias have become very rare because of the effective management. But diabetes is on the rise for various reasons. So one in
4 to 1 in 5 diabetics.
pregnancies.
Yes, it is becoming
So it
more
is
than
very, very
20%
important.
actually. Correct. So I just had a little bit to say, Deepti. I think your topic was a tough one, especially for the time given. In 5 minutes, it is difficult to cover this subject. Okay, but then you did try, and you brought in. See, Dawn and Somogi phenomenon are important to understand, but they are relatively rare. Nowadays, they are really, with better control, they are becoming rare. One thing which you probably missed out is to bring in the latest insulins, that are the insulin analogs which are being used. And the relative advantage and disadvantage would have been nice, because today we are seeing more insulin analogs being used. I agree that oral hypoglycemic agents and insulin together have resulted in better outcomes. So, one therapy you could have mentioned was that a combination of the two, and then the outcome related matter was a little less. So, I agree with Rajeshri that you should have spoken about pregnancy outcomes with the use of insulin. What have you gained by very accurate glycemic control, because insulin gives you very accurate glycemic control, and the counseling part of symptoms of hypoglycemia, which you have to explain to the family,
She
and the
mentioned that.
correction of hypoglycemia. How do they manage it at home? Simple remedies, as well as the most scientific method that could have come. You
But
mentioned
5
it,
minutes
but
only, I think it is.
5 minutes only
That's okay.
kashta. So this was a
Dipti,
very
Yeah.
vast topic.
Yeah,
But
5 minutes only kasta.
insulin analog and hypoglycemia, these two things probably could have been added, and the combination therapy.
and
Okay,
if
well
there
done.
is a chance, sometime you need to answer is insulin pumps are also there. So, but because of her time, she has been able to cover nice.
Yeah, she has been able to do
Thank
this.
you,
So that
Billet
is
sir,
good only. At
Rajeshri
least,
ma'am, and
yeah.
Dr. Shobha ma'am. Next, we move on to next topic. Candidate from JIMS Kalburgi, Samia Haturkar. Hi ma, your topic is on chocolate cyst. Your time starts now. Samia Haturkar, you're there?
Yes, ma'am.
JIMS, yes ma.
Good evening, ma'am.
Yes, very
First
good
of
evening.
all, chocolate cyst is nothing but it is ovarian endometrioma. Endometriosis is nothing but it is the ectopic endometrial tissue which is not present inside the uterine cavity but present elsewhere into the body. So if it is present inside the ovary, it is called as ovarian endometrioma, also called as chocolate cyst. First of all, why it is called as chocolate cyst? Because the endometrial tissue which is present inside the system, that will be responsive to the hormones of the menstrual cycle, that is
Please
estrogen
look
and
at the
progesterone.
camera and then speak. You're not looking elsewhere, please. All of you, all the students who are participating. You just only have to look at the camera and then present. You're not looking anywhere else.
Yes,
Please
I'm
continue.
looking at the camera. The cyst will be lined by the endometrial tissue, So this endometrial tissue will be responsive to the hormones which are present in the menstrual cycle, that is estrogen and progesterone. So as the woman will be bleeding cyclically in response to the estrogen and progesterone, so this cyst will also be responsive to these hormones. So it will bleed inside the cyst. So this blood will be collected, there will be hemorrhage. The collected blood, the hemoglobin which will be present, it will be degraded. There will be accumulation of iron. So it will be brownish color. So that is why we call it as chocolate cyst. The endometriosis, why it happens, endometrioma, there are certain theories. The theories like metaplastic theory of the endometriosis. It is nothing but the tissue which is present inside the ovary that undergoes metaplasia to develop into endometrial tissue. This is one of the theories. And there are different theories like Sampson's retrograde flow and metastatic theory and immunization theory. That is, if there is retrograde flow of the menstrual blood, the natural killer cells and the macrophages are supposed to clear it. But if they are unable to clear it, it will lead to the ectopic endometrial tissue getting deposited into the ovary. So these are the various theories. And apart from that, if there is any ectopic tissue over the ovary, there is invagination of this tissue inside the ovary, then it will lead to formation of this chocolate cyst. The signs and symptoms that the patient can have is she can have cyclical pain abdomen, pelvic pain, and if the cyst gets ruptured, it can lead to chemical peritonitis, and there can be torsion of the cyst, so which can lead to acute pain. We can give a conservative treatment to the first of all investigations on ultrasound. We will get homogenic appearance with internal echoes, and depending on the patient's symptoms and signs, we can give conservative treatment like NSAIDs and analgesia, gonadotropin releasing hormone agonists can be given to them, OCPs can be given. But if still the patient complaints are not subsiding, or if the cyst size is more than 5 centimeters, or if there is any rupture of the cyst, then we can go for surgical removal of the cyst. That is, we can go for laparoscopic cystectomy.
You're done?
Yes, sir.
Yeah. See, always when you are asked to talk on a particular topic, first of all, I congratulate you so that you have made a good effort to cover on the chocolate cyst. So your introduction should be the chocolate cyst is a type of endometriosis confined to the ovaries. Number one. Secondly, it is what is it? Usually, chocolate cysts are very rare to go for torsion. They are more prone for rupture because these chocolate cysts they are adherent and they get fibrosis. So that is why the chances of torsion is very less because torsion happens with the mobile ovarian tumors. Number three, the what are the important complications of this? They are known to cause menstrual disturbances. They are known to cause infertility. So these are the complications. Yet few of them I have told. There are many. They can cause bowel adhesions. There will be urinary extensions of these because it pulls the structures, and that point is not been taken care. And how you diagnose? You only just said ultrasound. Ultrasound ground glass appearance is there, but there are differential diagnosis for this aided by your some more biomarkers, right? And the complications of these are not very nicely covered. And treatment, you have got medical treatment, surgical treatment, and surgical over up and above medical treatment. That's the sandwich therapy sometimes can be used. So in whom what is best? How do we decide? And in chocolate cyst, what is the best mode? Which type of chocolate cyst we should treat surgically, which can be taken care by medical, and in married women where they are planning to conceive, when we go for surgery followed by either the infertility treatment or we directly go for infertility treatment. So these all are important points to be covered, which you are not been able to. So I am not very happy with your presentation. Please read well and make a good presentation. Okay, but my only point good about you is you are confident and you are able to make a good presentation. But I still feel that you should improve upon on this. So these are the areas which are deficient. I don't want to score you, Samia, but you need to improve on this. Thank you.
Students, you have been given the topic more than a week, I mean, at least 7 to 10 days earlier. Please make an efforts to make notes, and this will also help in your examinations too. Thank you, sir.
Yeah,
Rajashri
Manjula.
ma'am and Shobha Gudi ma'am,
Yes.
anything to be added upon?
Yeah, see, chocolate cyst or endometriosis on rise. And that is the reason we chose this topic, because this is one of the leading causes of infertility now. And the challenge becomes when a young woman with endometriosis or, chocolate cyst of the ovary is trying to conceive, then how do we manage her? What should be the size at which you go for medical therapy? At what size you decide for the surgical intervention? 4 centimeters is the size when you can, up to 4 centimeters, you could treat her conservatively, beyond which you should go for surgical management. And the practical points taken in precaution during the surgical methods is that the first surgery should be the optimum surgery. So all this require a lot of meticulous discussion, because chocolate cyst of the ovary is not just a cyst which is depicting in the ovary. It has a lot of pathological significance, that it is not only restricted to the ovary, there could be peritoneal spots, peritoneal spills, and everything which can lead to infertility. So knowing when to treat medically, knowing when to go for surgical management, why does it cause infertility, and how can you prevent and take precautions in the further occurrence of endometriosis or chocolate cyst, the recurrence of chocolate cyst, and then conservatively managing by giving the intracystic injections to reduce the chocolate cyst. All these are very, very meticulously described and dealt with even in the textbooks. So I think this requires more in-depth study of chocolate cyst of the ovary. Thank you.
So students, chocolate cyst is not just as simple as it
Eating
looks,
chocolates.
but it is really a very complex.
Yeah.
Yeah. So be very thorough in that. It is really a very complicated case too. So next, Sushma, are you there?
Yeah.
So please take over for the next topic.
Next, we have a student from MIMS Mandya. Dr. Tejaswini, are you there?
Ma'am.
Yeah, your topic is DHL diagnostic histolaparoscopy.
Yes,
Good evening.
you can start.
Yeah, you can start.
My topic is diagnostic histolaparoscopy. It is an endoscopic procedure where you visualize uterus from the abdomen and the inside of the endometrial cavity through hysteroscopy. It has two components, laparoscopy and hysteroscopy. In hysteroscopy, we evaluate the endometrial endoscopic contents like cervical canal, endometrial tissue, uterine cavity, and the tubal ostia is also seen. Whereas in the laparoscopy, we put ports from the abdomen and visualize the outside of the abdomen, that is the uterus, bilateral tubes, ovaries, pouch of Douglas, broad ligaments, and any pelvic peritoneum.
Please see the camera and then talk, not to anywhere else. See the camera and then speak.
Yes. Pelvic peritoneum. The indications are, it's a gold standard technique for unexplained infertility. When there is unexplained infertility, we do a diagnostic histolaparoscopy, and the causes for infertility, such as any tubal adhesions or any uterine adhesions causing Asherman's, and can be evaluated. And then any endometriosis, pelvic adhesions, and endometrioma, all that can be evaluated using diagnostic histolaparoscopy. We have two instruments like hysteroscope and laparoscope, where hysteroscope is done with it has a distension media. Distension media used will be normal saline or 0.5% glycine. The normal saline, we use it for bipolar cautery, and for glycine, we use a monopolar cautery. And first we do a hysteroscope, and we visualize the uterine cavity, the tubal ostia, and then we do a laparoscope using we do a laparoscopy by introducing a 10 mm or a 5 mm trocar by a virus needle or a direct approach. And then we will visualize the uterus, bilateral tubes, ovaries from the abdomen. And then for looking for infertility, we put Leach Wilkinson cannula, and we inject the methylene blue dye for this is called as a chromoperturbation test. It evaluates the tubal pathology for the causes of infertility. And then the the investigations which can be done before doing a DHL procedure is complete hemogram, LFT, RFT, CBC, ECG, and X-ray for anesthetic workup. And then after the procedure, there will be post-operative complications such as fever or the wound infection, and the patient should be mobilized early so that all the complications can be reduced.
You are done with, right? I am the expert, Manjula, for this candidate also, or somebody else is there? Anyway, see, your good name I forgot.
You have 2 more minutes to go. But anyway, Belet sir, you can take over.
Yeah, her good name?
Tejaswini, sir.
Tejaswini. See, you covered what is histolaparoscopy, but you didn't say that which one you will do first. Number one. Number two is that pre-operative evaluation, counseling plays a vital role. However, the procedure may be, especially in infertility, you must explain the procedure to the patient. So pre-operative preparation, not only just investigation, counseling plays a vital role, because you may injure the bowel, you may injure the vessel, you may injure the bladder, correct? And there can be perforation. So these, in a subtle way, it must be explained, and that is by counseling. If possible, nowadays, what like we do is we show the laptop, and this is how we are doing. Because first trocar is always blind, and most important is consent. And your findings, how you note in your discharge, you are doing this procedure. If somebody later on sees, it also should be seen as a proper record. Laparoscopy, what I should record, what should be about uterus, what about tubes, what about ovaries, what about pelvis, what about pouch of Douglas. There has to be systematic reporting. And then from the hysteroscope also, when you are doing it, how you are entering, what was the cervical canal, what has happened to the fundus, is there any depression, the osteas are seen, cavity is clear, type of endometrium, is it blanched, is it pink, is it polypoidal? All these points, the dictation of these findings. And most importantly, when you are discharging that, these are the important points which you have missed. I am pointing at you. The discharge instructions, patient can have unknown, you might not have missed the bowel injury. Patient may present with distension, she may present with fever, or there can be other complication with which she may not, but she should report that. So this discharge instructions must be very clearly told, and when she should come for you to the follow-up. These are all the important points you should be telling about diagnostic histolaparoscopy. Okay? So do you think the score is good with you? Good. Next.
Rajeshri ma'am?
I think she has pretty much covered what all are needed to do. And Sir has covered, in fact, all the things and points which are needed to be mentioned while doing the histolaparoscopy. And most importantly, we are doing a histolaparoscopy, especially when there is an indication of the tubal block, apart from unexplained infertility. So one has to do the counseling with regards to whether you will be doing any concurrent tubal reconstruction or recanalization, and all these things need to be detailed, discuss that, because one point entry, the patient, it's very difficult to convince and get them on the table for histolaparoscopy. So when you're doing a histolaparoscopy, it should be the optimum procedure and see that you give the best benefit to the patients. And Bhalat sir has really covered all the points which need to be noted down while doing a diagnostic histolaparoscopy, because these are of great concerns, especially when you're doing, because of it is an unexplained infertility, and what are the things which you're missing out in your routine assessment, and also for tubal blockage. Yes, Dr. Manjula.
Hello. Hello. Ha,
Yes.
Manjula.
Yes, ma'am.
Yeah, I just wanted to tell Tejaswini Janardhan that in today's practice of infertility, actually the role of DHL, diagnostic histoleproscopy, is very, very limited. Is very limited because imaging and good tubal testing, hysterosalpingography, and other agents like HICOC, they have actually replaced the value of just doing a DHL. So if you have planned anything procedural along with it, that is what Dr. Rajeshri is also telling you, probably that will benefit than just doing a diagnostic. So your topic, diagnostic histoleproscopy, I mean, the indications have become very, very few in modern practice of infertility. So you could have said that procedural interventions will go well with DHL. That is what is expected of you. And you heard what are they? Tubal hysteroscopy, tubal recanalization is one of an important interventions that can be done. And so also some other things like correctly picking up the tubal block, etc. Yes, but this is one of the main things which can be done. So just remember that, and you will do well. But diagnostic hysteroleptoscopy per se has got very few indications, and that if you mention, I think you score very good points. Apart from that, all the other points can be described what you said. So it was well done only. The understanding that it has limited role is what is needed. Okay.
Around the network is fine.
Okay. Yeah, and also Manjula, just make sure that every candidate is looking at the camera. I'm not very happy that
ma'am, we are warning them, we are requesting them
yeah,
everything.
so probably we
If they
should
do it behind
not
the screen,
accept the
what can we do?
presentation unless correct.
If they're honest, it's good for them.
Now, see, if you can see, now I'm looking at the camera.
Thank you, Bhalat sir,
Yeah.
Shobha ma'am, and Rajeshri
Yeah,
ma'am.
correct.
Yeah,
So they should
I
look like
understand.
that.
Then, yeah, today's last topic for student from James Gadag, Abhinaya. Your topic, Abhinaya, you're there?
Yes, ma'am, I'm there, ma'am.
Yeah, your topic is on angiogenic biomarkers in preeclampsia. And your time starts now.
Good evening, everyone. Myself, Abhinay, I'm from KH Patel Institute, which was previously
Yes, ma'am.
called Gadag.
Go ahead.
I'll quickly go for the topic. Angiogenic markers. Before going for that, we need to know the little bit pathogenesis behind the
You have to
preeclampsia.
see the camera, not any of
Yes,
the
ma'am.
study material, not laptop, not any gadgets, not any paper. You just have to see the camera and then speak.
Okay.
Time starts now.
Before going to the angiogenic biomarkers in preeclampsia, we need to know the pathogenesis of the trophoblastic invasion that has two stages. One is the placental and the next is the maternal stages. There is invasion of these placenta into the endometrium and myometrium, which invades the spiral arterioles so that there is adequate uteroplacental circulation. When this is affected, there is preeclampsia. And next, there is endothelial inactivation and inflammatory markers, which is second phase, that is maternal phase, which is bringing about preeclampsia. So we are more worried about the angiogenic and anti-angiogenic factors. So angiogenesis, there is decrease in angiogenic markers and increase in anti-angiogenic markers. The markers which is decreased, that is angiogenesis, are vascular endothelial growth factors and placental growth factors. And the anti-angiogenic factors that is increased are serum soluble FMT like thyroxine kinase 1 and serum endoglin These are the antiangiogenic factors which is increased. Both of them,
repeat the anti-angiogenic.
Soluble FMT like tyrosine kinase 1 and serum endoglin.
That's not correct. Anyway, go ahead.
Then anti-angiogenic factors are increased, which is the main pathogenesis behind the preeclampsia and PI or hypertensive disorders of pregnancy. We are measuring the score, keeping the soluble FMT like tyrosine kinase and the platelet placental growth factors ratio. And this, based on that scoring, we'll be able to predict if she's able to get preeclampsia in another 1 week or 4 weeks. If the score is less than 38, the ratio of that SFLT1 and placental growth factor, if it is less than 38, the probability of getting preeclampsia is very less. And if it is more than 38, the chances of getting preeclampsia in another 1 week is more. And by more than 30, even more than 80, it can be, or more than 110, it can be there. These ratios will help in finding out whether they are having the probability of getting preeclampsia in further advancing gestational age. And there are other things that helps in, helps or in pathogenesis is like thromboxane, prostacyclin, and which will help, which will cause uteroplacental insufficiency, which can lead
ಕ್ಲಾರಿಟಿ
to.
ಇದೆಯಾ? ನನ್ಗೆ ಬ್ರೇಕ್ ಆಗ್ತಾ ಇದೆ.
ಇಲ್ಲ, clear.
Okay, ಸರಿ.
There is these things causes uteroplacental insufficiency, which causes FGR and Doppler changes, which will help in interventions. Like if there is a less than 34 weeks, we might have to go for interventions of more than 34 weeks, depending on the gestational age and these changes. We have to decide, and we have to give tocolysis if it is less than 34 weeks, and plan for monitoring and biophysical profile. And angiogenic other markers which are increased or decreased, as I said, thromboxane is increased, and other prostaglandins are increased. All the growth factors, vascular endothelial growth factors are decreased. Placental growth factors are decreased. And also all these biomarkers, like 4 biomarkers predicting, will help in finding out the preeclampsia, and also in Doppler changes the persistent diastolic notch after 18 weeks. This will also be added to the diagnosis or prediction of preeclampsia. That's it.
Yeah. Abhinaya, it was very nice, but you must read what you are talking, that full form of those, very carefully. The confidence, I liked it, and you have tried to make your efforts on this. So whenever we cover about angiogenic and angiogenic biomarkers, means it includes anti as well as angiogenic. So first is, which are those two? There are two angiogenic. You didn't tell the other two anti-angiogenic also. There is soluble endoglin, what is one, and you have to correctly tell soluble FLM tyrosine kinase 1. Understood? That is SFLT. FLM like. You understand? FLM tyrosine kinase 1. That is SFLT. See, these are facing one another. Anti-angiogenic, this balance is lost. We are going to face the music, correct? And the woman manifests with, they are very specific to preeclampsia. And whenever there is a superimposed preeclampsia on a chronic hypertensive also, not general, all hypertensive disorders, they are not affected. It is mainly the preeclampsia and pregnancy gestational hypertension, and where there is a placental insufficiency like the FGR, and also intrauterine death where is anticipated. And these are the markers when the levels, you are told very clearly the levels of when you have got diagnosed, that what should be the SFIL to PLGF ratio. And similarly, you should have told about PLGF, which you didn't tell. That is, PLGF less than 12 is very abnormal, and where it needs to be delivered. And between 12 to 99, there is preeclampsia, which is likely, But you have to see the other clinical parameters and plan delivery. But if it is more than 100 PLGF in a hypertensive woman, that means it is not preeclampsia. Whereas SFIL to PLGF, it tells not only the diagnosis, it also tells the severity. You can wait for 85, you can wait for 110 of SFIL to PLGF there. So these components you must tell clearly how it guides us to deliver. These are the ones. And what are the latest developments of these also you must cover. The latest development is that there is a apheresis of this SFIL2 PLGF, SFIL antibodies from the blood that will at least prolong the very early preeclampsia. So how the plasma pheresis has come for many other components, that is called as apheresis of SFIL antibodies, which are taken away and then pregnancy can be continued. So overall you have covered, but these are all the conditions where it can get affected, these biomarkers. PLGF goes down, SFILT PLGF ratio increases, that means SFILT increases. So main idea is you have to tell this, and where they are produced from the trophoblast of the placenta. Okay, so these markers will help early in pregnancy. Their low levels help us to suspect and to start the condition like aspirin and low molecular heparin. So in the late, when the hypertension develops, it will help you whether is it really a preeclampsia or otherwise. Even in FGR, you can do this assessment, and it will indirectly help you to predict whether the baby how long it can survive. Okay, so please try to read more in depth. We are very superficial on this. Please read in depth. Okay,
Okay.
that's it. Thank you.
Rajeshri ma'am.
Yeah. First of all, the topics selected were such that 4 of them were dealing with the basics. Okay, so one has to know the basics topics which we have done so far in the first 4 topics. The last one was the recent advances and a research-oriented topic wherein Dr. Bellat sir is a master in this, and he has published and done a lot of work in this aspect of angiogenic biomarkers. And this was done way back, I think, sir, 5 years back. You're muted, sir. You're muted, sir.
No, the biomarker study is now we concluded with the cradle trial and all, but now we are really looking into coming with a point of care test, wherein how you have got glucometer tests, you put one drop of blood and you will get the glycemic level. Like that, we get point of care test for PLGF as well as SFILT and SFILT to PLGF ratio. These are all devices we are testing now. Soon, when I think probably Abhinaya becomes a consultant when she completes her degree, she will have point of care test. Don't have to struggle, do all these tests and then decide that how I should manage hypertension in pregnancy.
So I really don't have any comments on this because you have heard it from the master himself who has been doing the research and a very, very focused study in prediction of the hypertensive disorders of pregnancy. Only thing I would like for the PGs to take home the message is that this carries a lot of significant predictive value and timing of the delivery. And you should know by heart the values at which you should be taking the decision to terminate the pregnancy or wait for the pregnancy or observe the pregnancy. So this is one aspect which is very important, futuristic, because you can really prevent and predict the intrauterine deaths or complications which are occurring as a sequelae of hypertensive disorders of the pregnancy. So, dear students, we truly appreciate your spontaneity and your sportsmanship to participate in this program, because I'm sure I can I can pledge for this that all of you who have presented today will definitely for your lifetime remember this topic, because once you read, once you present, once you make mistakes, this is the platform to make mistakes and correct yourself, because rest of the life you're going to remember all that you have read today, and you have to enhance your learning about this. So congratulations for all the students for taking up the topics, and I truly appreciate the heads of the department for motivating the postgraduate students, because until you come forward, I think this program will not be a success. And I think at one point in time, we had 70 logins, which is a very, very good response. And we hope that in the future, that many more active participations will be there. Dr. Geeta Doppa, I see you there. And thanks
Good
for
evening,
logging in.
ma'am.
PG also did well. She spoke quite well. And this will bring in orientation for the, and most importantly, competitiveness, and helps us to understand where we stand on this platform of understanding of postgraduate training, that pretty much everybody is on the same platform. And only thing now that with the connectivity and with the internet availability and the learning process, which has become so very nice. Back then in our postgraduate days, either we had to go to the library or go to a bigger place like Mumbai or Hyderabad or Bangalore to know more about
Yeah.
these classes and things. So this is very
True.
fortunate for the postgraduates that it is coming at your doorstep from the masters. Like you see, Dr. Bellat sir has done so much of work in his this 5 minutes is just nothing for him to cover up on the angiogenic
Yes.
biomarkers. But yes, thank you very much, Dr. Manjula, Dr. Sushma.
Rajeshri, 1 second. I want
Yes,
to say a thing to
yes.
PG. Uh, Dear postgraduates, you all have done very nicely, and I really liked the confidence. That is one point. I think you need to read and learn these communication skills. I want one suggestion to all the postgraduates: read the ACE book of soft skills, and that will tell you how we should communicate, how we should effectively communicate, how we should counsel, how we should convince. And these are the arts which you need to learn in the examination. Though you may have the subject, the convincing, counseling, and communication art is very essential. I once again congratulate all of you for a bold and confidence presentation, but need a little more depth of knowledge, I feel so. And I think they have whether assisted some of the procedures or not, I don't know. So please see that your practical skill is also important. Thank you so much. All the best for your exam. I hope you all will clear your examination.
Yeah, I just wanted to, Rajeshri, can I speak for a few seconds? Yeah.
Yes, please,
Hello.
please.
Yes, ma'am.
Yeah. So very well summed up by Dr. Rajeshri and Dr. Bellat. I think the PGs really stand to benefit. I just had one word of advice for the last presenter. As both, I think Dr. Bellat very clearly said also, we are looking at a major simplification of these biomarkers now. Actually, it is getting more and more simplified and easy to implement in future. But very importantly, you must be able to predict on a clinical basis also. So we have a good score which works for us clinically, just as a score. Of course, your question was about biomarkers, but I'm just telling you that clinical prediction and is actually very good. You must become very deft in clinical assessment of the risk factors for preeclampsia and try to do the best to mitigate the risk. Even based on clinical gestosis score, you'll be able to start the prophylactic aspirin, because after all, what you can do to prevent is only that much today, and intense surveillance. Nothing else can be done, even though you predict, right? Timely delivery later on, of course, but early prediction, that's the major intervention which can be done. So very well summed up by both the seniors. So I think it is okay to conclude now, Manjula. Over to you and your team. Yeah.
Manjula, if there
Thank
is a time, I think Dr. Geetanjali Katagiri is there. Can you just ask her to speak something on biomarker?
Dr. Geetanjali, are you there?
Yes, ma'am, I'm here.
Yeah.
Well, let's say when you are online. Well, let's say when
Yeah.
you are online, I think you would have majorly covered everything. So, yeah, I just wanted to just reiterate what Bellat said. I joined very late. I just joined when Bellat said was speaking, actually. And he told about the point of care tests which are being evaluated. So I think we are going to get some headway into actually tackling this very enigmatic and difficult disease for all of us. So I think over the next few years, definitely, we will come out with some some definitive ways of understanding which patient needs to be delivered and which one we can continue.
Yes.
Bellat sir, you have said it all. Thank you.
So I thank Dr. Rajeshri ma'am for giving this opportunity to go ahead with pedagogy, and it's going to be a benchmark. And from next time onwards, I request all the HODs, please, I request you tell your all the PGs to join this, because this is first of its kind, and definitely it is going to lessen your burden, as well as it will also make the students prepare well. So for this event, HODs, Dr. Geeta, Dr. Hanmant, Dr. Jyoti, GS, Dr. Usha, and Dr. Savita, I thank you all for giving your time, and also make your students to get prepared well. So henceforth, please tell your students to join. We will also tell in advance to get prepared, and also make them totally prepared for this. So thank you one and all. Thank you, Bellat sir, and Shobha ma'am, and all the team Kasoga for making this a grand success. So thank you one and all.
Good night.
Thank you
Good
and
night.
good night.
Thank you.
Yes, sir. Thank you, sir.
Thank
Thank you,
you.
ma'am. Thank you.
Thank you so
Thank you.
much.
Thank you.
Thank you, ma'am.